Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Rheumatologists spend a lot of time thinking about early rheumatoid arthritis. We try to diagnose it quickly, treat it aggressively, and take advantage of that window of opportunity before irreversible damage occurs. But what if we're still starting too late? For many patients, rheumatoid arthritis begins years before the first swollen joint. Autoantibodies can circulate for 3, 5, sometimes even 10 years before disease is actually diagnosed. The immune system has already broken tolerance. Something is happening, perhaps in the lungs, in the gums, or in the gut, long before we ever diagnose rheumatoid arthritis in the clinic. But is there anything we can do to stop rheumatoid arthritis before it begins? My guest today is Dr. Kevin Dean, one of the leading researchers trying to understand exactly how rheumatoid arthritis develops and how we might eventually prevent it. Dr. Dean is director of the Autoimmune Disease Prevention Center at the University of Colorado Anschutz, and he's also professor of medicine and endowed chair for rheumatology research. We talk about what a positive CCP antibody actually means, where RA may begin, what he learned from the STOP RA trial, whether rheumatologists should screen people at risk, and what we should actually tell that patient with CCP positive antibodies who is sitting in front of us today. Enjoy.
Kevin, welcome to the show.
Great, thanks for having me.
We're going to be talking about whether we can prevent rheumatoid arthritis, which is a topic I'm sure of interest to a lot of clinicians and certainly a lot of patients out there that may have rheumatoid arthritis. I think before we get to talking about antibodies and biomarkers, clinical trials, can you answer the question, is rheumatoid arthritis preventable?
Yes, with a bit of extra work, but hopefully in the near term.
That's awesome. Do you think we could say that it's delayable rather than preventable, or what's your take on that?
I think ideally we want to get to prevention, and I think that's doable with a bit more work. Right now, I think we've already seen some data that we can delay the onset of the disease in high-risk people. So delay first, prevention later, but prevention is where we want to go. But both are great.
Awesome. So let's talk first about a patient that we're seeing in our clinic. Maybe they have swollen joints in the hand. That's sort of the end stage when they already have rheumatoid arthritis. Can you walk us backwards from that swollen joint? What has been happening inside the body during the preceding years before that patient presents to our clinics with rheumatoid arthritis?
Yeah, great question. So before that joint first becomes swollen that a rheumatologist can see in the clinic, as you say, that's what we call, this looks like rheumatoid arthritis and they'll treat it as such. Before that, that person has likely had circulating autoimmunity for several years. Some studies think on average 3 to 5 years, autoantibodies have been circulating in that person. Some studies show up to 17 years before they got that first swollen joint. So sometime in the past, they've broken tolerance to their self, and they've had brewing autoimmunity that's detectable in the blood, but that hasn't hit the joints and caused that inflammation that we call synovitis yet. And again, on average, 3 to 5 years, but it can be quite a long period of time.
Yeah. Do you have any ideas of why and how the body breaks tolerance? Where does that first begin?
Yeah, it's a hot topic right now. I think some of the best emerging data is that we probably initially break tolerance somewhere else in the body, not in the joints. It's not the first place in RA. Perhaps at a mucosal site like the lungs, the gut, maybe the gums, maybe the cervical vaginal tract, maybe different for each person as they journey on their pathway to RA. But at those mucosal sites, we have influences like microbiome, bacterial stuff, environmental things like cigarette smoke that trigger our immune system to go awry, start making autoimmunity that can brew in some people, resolve in some, but then can grow, then transition from just being a mucosal process to becoming circulatory, again, brew and grow till it finally transitions to where it's now attacking the joint.
So when you mention those autoantibodies, do you mean like ACPAs, like the anti-citrulline
Yeah.
peptides, or others, rheumatoid factors?
So certainly there's lots of autoantibodies. What we like now are ACPA, or antibodies to citrulated protein antigens, largely because those are highly specific for rheumatoid arthritis. And if they're circulating, it gives us sort of the best guess that you are at least on a pathway towards rheumatoid arthritis, even though everybody who has those antibodies still won't go on to get RA. But those other antibodies also contribute rheumatoid factors, and we're growing our understanding. Now there's antibodies to carbamylated proteins, or things such as the peptidyl arginine deaminase. So a whole host of antibodies, but ACPA are the primary ones that I think give us a good indication someone's broken tolerance and is heading towards what we are going to call clinical RA, where the joints are actually inflamed.
And do you see the titers of those antibodies grow over time in patients that eventually develop RA?
Yeah, they do. As a large, high level start low and very early breaks in immune tolerance of these things, and then increase over time as immunity and autoimmunity expands. However, there's not some magical transition point where we say, oh, your level is over X, then you're going to get rheumatoid arthritis. It can be pretty variable. But in general, the higher the levels, the more likely you are to develop rheumatoid arthritis. What exactly comprises all that risk is hard to know. We're not sure if the high levels actually indicate you're making more and different types of autoantibodies. This is going on. So that's something for the future to sort out. But at a punchline, high levels of ACPA and other autoantibodies, or combination of antibodies, are really indicative that you've really progressed and are getting closer to getting rheumatoid arthritis.
And does the number of autoantibodies also increase over time?
Yeah, it does.
The diversity of autoantibodies, as you say?
Yeah, there's a couple levels to that. In a clinical setting, we can see that by saying, oh, you have both an ACPA, like an anti-CCP test, which is our common test, and a rheumatoid factor. Those are tests we can easily get. So if you combination of those two, that's more likely to progress. In research level, we have ways to break those antibodies down into multiple subparts, so to speak. So ACPA are the ones that I think have the most data. You can do ACPA to a whole bunch of different targets, like fibrinogen, vimentin, histones. The more antibodies you have to each of those targets, you've progressed further towards getting rheumatoid arthritis.
And do you have any idea why an ACPA affects the joints and causes swelling? Like, what is it about these? Is it sort of like a mimicking bacteria, or what's the process that happens inside the joint?
It's a great question. There's still some controversy. We do have some good data from animal models and humans that ACPA can actually target citrulated proteins within the joint, then drive complement activation and drive inflammation themselves. Once they target the joint, they can also bring in cells, T and B cells and neutrophils, all that drive inflammation. So they're directly pathogenic in that way. The ACPA also can participate in immune complex formation with rheumatoid factors or other antibodies. Those immune complexes can pile up in the joint and trigger inflammation. The trick to that is there's probably ACPA that are actually not pathogenic and may even be protective. That's sort of a wave of the future to sort that out. If someone comes in and has high ACPA but not arthritis, are those ACPA actually protective? Or are they not somehow in other ways pathogenic yet? So that has to be sorted out. But to the back to your original question, the ACPA can directly participate in triggering joint disease and rheumatoid arthritis. That doesn't explain people who might get rheumatoid arthritis who are ACPA negative or rheumatoid factor negative. And then for this conversation, I'll just say we don't know as much about how seronegative or autoantibody negative rheumatoid arthritis develops. So we're really talking mostly about ACPA and rheumatoid factor positive disease.
So when you see ACPAs in a patient, has rheumatoid arthritis already started, or have they just developed another risk factor?
Yeah, that's a great question. I think the best way to describe that now is they've developed another risk factor.
Okay.
We're hesitant to call them as having rheumatoid arthritis because we now know sort of our best models are if you're ACPA positive, really only 30 to 50% of people in that situation actually go on to get full-blown clinical RA. So to call them as having RA is tricky. That said, some people who are ACPA positive have musculoskeletal complaints, joint pain, stiffness. They perceive swelling even though we may not see it as a clinician. It's difficult to know what that stage is. And is that something we could more legitimately call a rheumatoid arthritis state? That remains to be seen. That said, if you're ACPA positive, we're trying not to call it RA. Now, what you may ask, what are we calling it? This is up for debate. I think we're now calling it an at-risk state, kind of to your point. If an ACPA positivity or other autoantibody is a risk factor, then they're in an at-risk state. There's some challenges with that because everybody without rheumatoid arthritis could technically be considered at risk for future disease. So it may be called a high-risk state. Anyway, the nomenclature needs to be sorted out, but an at-risk state now I think works pretty well.
Yep. So do you envision, is there, as over the years patients are developing higher, tighter antibodies, maybe more autoantibodies, is there a point of no return where the patients sort of are bound to develop autoimmunity, or can this ebb and flow sort of both ways?
Yeah. At this point, I think, yes, there is for some people an inevitable point that they've crossed over and they will definitely start developing the disease. That said, we don't know exactly how to determine that for each individual because we've seen people with very high titers of autoantibodies go for years, even decades, and never get rheumatoid arthritis. In clinical care, I think a lot of rheumatologists have seen people who have what we call palindromic rheumatism, where they may have high rheumatoid factors and CCPs, get synovitis that you actually see, but that resolves on its own and it doesn't come back even in absence of therapy. So there probably is an inevitable point. We just need to sort that out. And that'll be a key factor going forward because once we know that, I think we're going to be all comfortable in saying, oh, that's someone we need to treat now to stop it from going on. The other people, we may be able to watch a little bit or be more gentle with them without having to jump in.
Great. So let's talk about a patient scenario that I think we've all seen in our clinic. Let's imagine a 40-year-old woman who presented to the PCP with some joint pain. You know, they run Lyme titers and ANAs, rheumatoid factor CCP, and she turns out to have a high CCP antibody. She does have a family history of RA, and we're seeing her in clinic. There's no obvious synovitis.
Yeah.
She asks you, do I have RA? Am I going to get it? Can I prevent it from happening?
Yeah.
How do you talk to patients about this scenario?
Yeah, I'll walk through those. So first, we say you don't have RA. If we can't see synovitis, we can't really define you as having rheumatoid arthritis. It's a little tricky if they have some musculoskeletal aches and pains, and imaging is sort of changing how we define arthritis now. We may talk about that a little bit later. But I would say you don't have RA if we don't see a swollen joint. Next is you may get rheumatoid arthritis in the future, and it's something we got to watch for. The exact numbers to tell that person depend on a lot of factors. I like to just keep in my mind 30 to 50% of people who are ACPA positive will go on to get rheumatoid arthritis within 3 to 5 years at a high level. You can refine that with some published prediction models that I won't go into huge detail right now, where if you start factoring in age, family history, their specific symptoms, levels of pain, you can inform that prediction. But roughly 30 to 50% of ACPA positive people will get RA within 3 to 5 years. You can tell them that. As far as prevention, we don't have, at least in the United States or in the world, regulatory body approved intervention yet, where we can give them a drug and say this will definitely, and based on research studies, prevent you from going on to get rheumatoid arthritis. That's coming, and we'll talk a little bit about that later, about what we've seen in studies so far. We say we don't have any proven preventive interventions. However, there's a few recommendations for lifestyle that I think are beneficial in the whole for people's health in general, from terms of cardiovascular and cancer health, but they may also help reduce risk for rheumatoid arthritis. This includes smoking cessation, a Mediterranean type diet, exercise, and maintaining a healthy body weight. There's some controversy whether periodontal care or gum care can help prevent rheumatoid arthritis, but because we think good dental care is good for a lot of things, it's probably reasonable to recommend that. Other things like supplements are less well studied. There was a study called the VITAL study. It was a large study designed for cardiovascular disease cancer outcomes, showed that people on vitamin D and or omega-3s had reduced rates of getting rheumatoid arthritis among other autoimmune conditions. It's hard to know how to apply that in someone who's CCP positive because those folks weren't studied. People have argued that, well, vitamin D and omega-3 supplementation is pretty safe. You could try that, but I don't think it's a hard recommendation. It's really focusing on lifestyle. They also have these people be very aware they can get rheumatoid arthritis and watch their symptoms carefully. Got to watch that balance, not to have them freaking out all the time about every ache and pain, but I think they need to be aware because at the very least, we know if you can diagnose RA as quick as possible and get them on the right therapy, those people have good outcomes. I think that's well established.
Yeah. I wonder, are there imaging studies or lab studies that may help you predict whether that patient may develop rheumatoid arthritis? Would you get ultrasound or MRI in one of
Yeah.
these patients? And if you see anything, is that now RA?
Yeah, that's a great question. So lots of studies have looked at both ultrasound and MRI of joints to see, can that help us not only predict future rheumatoid arthritis, but perhaps identify rheumatoid arthritis now that our fingers didn't feel when we examined them. I think the question still is out there on how good these tests are to identify someone with RA or not. It's a little controversial, but MRI has been shown to improve prediction of someone who's going to go on to get full-blown RA that you would identify on a clinical setting, i.e. I see a swollen joint on physical exam. So it may help you predict who's going to go on to get disease. Right now, there's no clear clinical guidelines on what to do if someone on MRI or ultrasound has what looks like synovitis or even tenosynovitis now, but you don't see anything on exam. So that's up to the individual clinical care provider on how to handle that. We don't have clear guidelines. That's something the field really needs to do, because imaging is getting far more popular across the globe, and people, especially if they have aches and pains and you see something on ultrasound and they're CCP positive, we need to have a better idea what to do with that. Right now, it's kind of up to the individual clinician. There's no clear guideline.
And for that patient that's sitting there, maybe either you don't do the ultrasound or she doesn't have it, is there anything that we can actually do to prevent her from developing rheumatoid arthritis, right? Because we know that she's at high risk. She has a family history. She has high positive CCP. Are we going to do anything differently?
Yeah. So again, there's no regulatory body like FDA approved intervention yet to prevent disease. But there have been a couple of clinical trials that have been somewhat informative. The ones that were most successful are 2 trials with abatacept in patients similar to this. The 2 trials are called APIPRA, and then the other one is called ARIA. Slightly different inclusion criteria, won't go into huge detail. One of the studies actually used MRI finding of inflammation as an inclusion factor. Both, they required CCP positivity, either at a high level or in combination with rheumatoid factor. Anyway, abatacept in both those trials, given for either 6 months or a year, delayed the onset of full-blown rheumatoid arthritis defined by a swollen joint on examination, even up to a year after stopping the study drug. So whilst on study drug, rates of developing swollen joints was incredibly low. And then even after stopping drugs, while people started developing rheumatoid arthritis, the rate still stayed lower in the people who got drug, suggesting at the very least that while on study drug with abatacept, you can delay the onset of full-blown RA. Even after stopping the drug, there may be a period of time when you've delayed the disease. So I think delay is probably the biggest outcome from those studies. A couple other key studies that didn't show significant benefit. My own group, we did something called the Stop RA study, where we looked at hydroxychloroquine for a year to see if we could prevent rheumatoid arthritis at 3 years. Drug didn't work. Even while taking study drug, people didn't feel better, didn't reduce rates of rheumatoid arthritis. So while hydroxychloroquine was sort of attractive to use in these people, given its safety and tolerability, I don't think that's the right choice. Another study called Treat Earlier used methotrexate. Similar to what was seen with the abatacept studies, while people were taking methotrexate and if they were CCP positive, they actually had reduced rates of developing rheumatoid arthritis and felt a little bit better. However, there wasn't a lasting benefit once they stopped methotrexate, so that at the end of the study, they lost benefit. Important to keep in mind, all of those studies had this sort of shoot the moon approach where they only used drug for a short period of time and then stopped, hoping that we were going to reset the immune system. We didn't really see that, so I think going forward, we got to figure out different approaches. Even with the abatacept study, you may wonder, should we just keep this going or intermittently dose it? That might be a better effect.
Yeah, I think the only other study is the rituximab study that I think showed the same thing, right? It delayed the onset of arthritis in a high-risk population, but it didn't sort of eliminate patients from developing RA.
Yeah, and that's an interesting finding across these studies with, glad you mentioned rituximab, abatacept, and methotrexate. We'd all hoped if you catch people at this early stage, it'd be easy to bump their immune system back to normal. You just really don't seem to be able to do that. Whether we're intervening too late or it's just not the right intervention yet, I think we need to learn more.
Yeah. I always wonder, should we screen for patients who are at high risk? Nowadays, I don't know if you've had patients that they do these they go to these labs where they get 100 different lab tests done, like Function Health. I was looking at them, right? Rheumatoid factor and ANAs are both included there. So these would be, in general, patients that are probably asymptomatic, and you may find that they have a positive rheumatoid factor or a positive CCP. Is that a good thing? Is that good knowledge to have? Should we be screening more patients like this, or can that cause some harm?
Great question. Controversial area. The whole business of screening and prevention, no matter what disease you're talking about, is always fraught with challenges. I think we've seen in the news, right? Like even breast cancer screening, mammography, or prostate screening, always fraught. You can go different directions. My personal belief is I think I would love us to get to the point where we're testing asymptomatic populations for risk for rheumatoid arthritis or even other autoimmune diseases, much like we do cholesterol screening now, right? We test, everybody gets cholesterol screening in the United States at age 35 or 40. And then we act on that because we have good data. We know what to do with it. I think what we'll need to do for the next step is to understand exactly how to use those biomarkers to accurately predict people, and then have, of course, an intervention. So we're not just telling people you're at risk for RA without clear-cut guidelines and how to manage that. But I would say my personal goal would be to get to the point where we are screening. I think we're pretty close. In full disclosure, I'm working with some groups, including the U.S. Preventive Task Force. We've had discussions about this. How would you actually implement so you could add a CCP to your panels? A few more data points to get, but I think that's something that could happen in the near future. I'm going to sound snarky about other diseases, but you have to keep it in mind with cholesterol now, we often give statins to people, knowing that the number needed to treat with a statin is like 40 to 60 people to prevent one non-fatal MI. That's a lot of treatment. We can probably even understand risk and prevention better with rheumatoid arthritis, but we still have to get the numbers to get there. One success story I'd like to mention is type 1 diabetes. They now have models similar to RA where autoantibodies appear prior to the onset of type 1 diabetes. They call their pre-diabetes stage stage 2 type 1 diabetes, where you have 2 or more autoantibodies, mildly elevated glucose, but you don't require insulin. They now have the immune modulating drug teplizumab approved for that population to delay the onset of stage 3. So FDA has approved that now. All the endocrinologists are working on how do you screen and how do you prevent. Their benefit is they have the drug that's approved. So that's where we need to move next in RA, get something we can now do with that risk state.
Right. I think a question that I get asked is, if you see a patient with RA, they always wonder about their kids. So should you screen first-degree relatives of patients with RA for like ACPAS?
Yeah.
I guess you're saying maybe in the future we should, but maybe at this point, not so much?
At this point, in terms of routine clinical care, I'd say no, we don't have approved pathways to understand that. I would say first-degree relatives of people with rheumatoid arthritis are at higher risk for RA. Yeah, I think some of the numbers are your lifetime risk. If you don't have anybody in your family with RA, is probably 0.5 to 1%. But if you have a family member, it goes up to 5 to 7%. So it is an enriched population. That said, it's not that high. It's not like some other diseases like type 2 diabetes or heart disease, where family risk can impart like 50 to higher percent in certain people. So it's certainly a group that I think we should think about operationalizing screening in the near future, but I don't think we're quite there yet.
Yeah. I'm wondering, you brought up that we should do trials and have medications available for these patients that are at risk, but yet don't have disease. I'm wondering what you learned from Stop RA, that, if you had all the money in the world and you could develop a clinical trial to try to prevent or delay RA, how is the learning from the Stop RA trial sort of guide you? Like, what type of medications would you use? Who would you include? What would be the outcome of the trial?
Yeah. There's a lot there. First thing, it was very hard to find. Let me step back. Stop RA trial, we took people who were anti-CCP positive at a level 2 times the normal cutoff. We use a particular test called anti-CCP3. If you use that clinically, the normal cutoff is 20 or greater. We use 40 or greater. That eliminated a lot of low positivity, which we think may be lower risk or may fluctuate. And we've done some pretrial estimations that about 50% of those people should get RA within 3 years. We estimated a little too high. Only about 35% of our people did, but it's still not too bad. But finding those people was very difficult. We relied on 3 approaches. We did widespread testing. I'm in Colorado, so we used the Colorado Health Fair. We just went out and tested people on the street, much like you're talking about, like a screening. We just said, hey, we got an RA study. This is not for your clinical care, but you want to consent, get this test done. We did that. We also found people in rheumatology clinics. Somebody comes in with aches and pains, much like the lady you just described. They wind up being CCP positive. We tried to get those people out. It was very hard. We worked over 4 years, a little longer, to get 144 people in that situation. And it's just tough. So for the trial, I'd say if we could develop networks across the United States or even globally of finding people who happen to be CCP positive and understand who they are, where they are, so they can feed our trials, I think that's going to be critical. This is slightly different than doing regular clinical care screening, but I think all rheumatologists see at least a few of these people. If we can get those people plugged into a system, that'll drive studies. To your other point of what do we want to do next? Well, I think that much like when you have full-blown rheumatoid arthritis, there's a lot of different pathways, a lot of different drugs work. We need to think about this pre-RA period in the same way. I think we just need to find the people who are at risk and start trying different drugs. You maybe be smart about it and try and identify biologic pathways that make the most sense, and certainly safety is going to be an issue. But I don't think I have a magic pathway that we need to target to prevent RA. I think we just need to start getting the people in the pipeline and work on our way through a variety of interventions. If I can harken back to type 1 diabetes again, they did a lot of studies to find finally a drug, teplizumab, which is an anti-CD3 drug, that would actually work to delay the onset of type 1 diabetes. So I think we probably have to follow that same model. Best guesses, but get the pipeline of people who are at risk and then just work through the trials.
So I'm just wondering, if you repeat a trial, would you consider the abatacept trial to have been successful? Did they achieve the outcome that they wanted, or are you just delaying disease? And is that going to be the end result of other drug trials? Or do you think we're actually going to find something that may help to reduce the ultimate risk of RA development?
It's a good question. I think our goal still should be a reset, if we can do that, where we hit somebody for a brief period of time and then we reset their immune system back to normal. That said, it's still successful, I think, to delay disease. I think what I learned from the abatacept studies is that on-drug benefits were quite good. People felt better, even though they didn't have full-blown RA, and you delayed the onset of the swollen joints of RA. I think we can look at those trials and redesign the next ones to perhaps redose drug over time, because all they did was treat it for a year, stop. What if you treat for a period of time, stop, reassess, then retreat if they start to have either biomarker changes or symptomatic changes? That still may be a great success if you actually delay that first swollen joint, and even if you have to continue drugs, because I think we could do that in a much safer fashion than right now with RA, right? Somebody comes in, they're on drugs forever. But if we could do strategic redosing, is a term people are using, that might be helpful. The big reset, we're wondering, we just think that was hard, but maybe there are ways to tolerize people. If you're at the very early stage, if we address some lifestyle stuff, maybe fix inflammation in your gums or your gut, maybe do some tolerizing approach, maybe that's the time to do it. Those people would be incredibly hard to find, though, because they wouldn't have come yet to even rheumatology clinic with aches and pains. So I think there's a lot of ways to think about where we would target. So I don't have a clear answer, but I think if I was going to do a trial immediately based on what I know about, I might similarly design it to the abatacept trials, but redose the abatacept. The other part to that is we're getting better now, even in the abatacept trials, maybe step back, less than 50% of people actually got RA in the original period of the trial. Even at 4 years follow-up, the rates was still around 60%. So 40 to 50% of people still didn't get RA. We're getting better at selecting out of all the people who are ACPA positive, who's really going to go on to get rheumatoid arthritis in a short period of time. And the studies are still underway, but if we could focus on those people who have the highest risk features. Early data suggests multiple autoantibodies, more symptoms. Those are probably the people that are going to be best to target with the next wave of prevention studies.
And do you think that there is sort of like a window of opportunity where you hit these patients early in the disease course and you actually make the rheumatoid arthritis easier to treat over the long term? We all have these patients that are difficult to treat RA. I always wonder, had we sort of gotten them early, gotten them on biologics, would we have changed the disease score so that they are ultimately easier to treat?
Yeah, great question. We already sort of know that in established RA, if you catch them early and get them on drugs, they have a better chance at being on less drugs and less biologic use later. But that same model seems to be applying if you find these people in this pre-RA stage. One study I think that made that point very nicely was the treat earlier study with methotrexate. So your methotrexate delayed RA while they were taking it. They lost the effect after they stopped methotrexate. But when the people did develop rheumatoid arthritis, it was a milder form if they had been on methotrexate than if they hadn't been. And longer studies are still pending off of that. But that's a great goal, right? If you can transition RA from a disease that's ultimately going to require multiple drugs just to something that's very mild with maybe one or two drugs, I think that's great. I think that should be a goal. That wasn't a primary goal of these original prevention studies. We really tried to just prevent RA or not, but I'm glad that there's data emerging from that. Yes, we could modulate RA. Another point I'd like to touch on is a lot of these people who have been in the RA prevention trials actually got identified because they had aches and pains. And my own experience talking to these people, it's hard to say, I know you have aches and pains and you're CCP positive, but you don't get rheumatoid arthritis. I wouldn't normally treat you, but here you can join a study. I think we need to think about those symptoms as actually an endpoint. In the next round of studies, I think are going to start looking at that more. Right now, those were all secondary endpoints in these trials. But I think that's an important part because if you're CCP positive and you have aches and pains, we should probably just try and make you feel better. And there may be great approaches. Just make you feel better. And if we can also prevent full-blown RA later, that's another goal. So I think that'll be a focus of trials going forward as well.
Yeah. But I wonder if you have thoughts about that patient, like sitting in front of you in clinic who's CCP positive, having aches and pains, no clinical synovitis. Should a rheumatologist prescribe methotrexate?
Yeah. Right now, we don't have guidelines. I think so. I'm gonna hedge an answer there and say that's up to the clinician. Again, if you throw in, and I do an ultrasound on that person and I see a bit of synovitis somewhere, which can be easy to do depending on the ultrasound and the technology, do they then have disease? That is not something we have clinical guidelines for. And I think the field needs to help guide us. At this point, it's up to the clinician. But I understand the question and the problem. I just wish I had a better answer.
Yeah. So what do you think is the biggest obstacle sort of in this area of preventing rheumatoid arthritis? Is it, as you mentioned, is it finding those high at risk patients? I mean, you had a tough time with your Stop RA trial. Yeah. Is it finding the right drug, the right clinical outcomes? What's missing?
Yeah, I wish I could have one point and we could all just go at that. I think it is multiple factors. It's finding the people who are at risk, at higher risk in general. It's then stratifying those folks into those that are the highest risk and lowest risk. It's also then figure out what the biology of each of those states is so we can then target it. And then it's getting the trials done so we can prove something works in those people. Because unless we get, regulatorily approved agents, we're never going to make this an actionable prevention. That's why I speak fondly of type 1 diabetes. They went through all this work. They stratified their people. They had big networks to find their people. They understood the biology enough, finally got a drug approved. I think we got to work at all those things. So if I can recap the 4 things, find the people, risk stratify them so we know who's really at risk, understand their biology, and then just start targeting that biology in probably multiple trials to be able to actually get an approved drug. All that said, I think we know enough now to really move ahead trials. You'd asked about this. I think trials where we may consider abatacept in different dosing regimen now, it's a great idea. I think there's a lot of other therapies that are coming out that we could still try. I think the JAK inhibitors are an interesting idea for moving earlier in rheumatoid arthritis. I hate to say CAR T therapy. I mentioned reset earlier. We're seeing some exciting data with CAR T therapy in some immune diseases like lupus, where it does seem to perhaps reset things. Now, whether you want to give an intervention with the potential toxicity of CAR T therapy in this early pre-RA state when the person actually may feel pretty good, that remains to be seen. But what an interesting thought if we could use some therapy like that to actually truly reset, hit them once, and they're done with their rheumatoid arthritis forever.
Amazing. Kevin, this has been an awesome conversation. I would love to have you back. Maybe once we have some more of those studies and that data. I think all of us are sort of both patients and physicians are anxiously waiting for data and information because we're all seeing these patients, right? We all have, there's many patients out there with positive autoantibodies who aren't feeling well and would love to be able to provide them with something, ideally to prevent their development of RA in general. So I look forward to all those studies.
Great. Well, hey, thanks for having me.
What I found most interesting about this conversation is how rheumatoid arthritis prevention forces us to reconsider something seemingly simple. When does rheumatoid arthritis actually begin? And also, can we identify not simply who is at risk, but who is approaching that moment when autoimmunity becomes inevitable, and then intervene precisely at that time? Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and all other episodes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep an eye on those CCPs, but perhaps don't just order them for everyone just yet. And of course, stay healthy.
This podcast was edited by Resonate Recordings.